Welcome back everybody, David here with Med School Bootcamp. So now we're going to dive into our nephrotic syndromes and really talk about the specifics of each of the common ones that they want you to know for test day. So the first one we're going to talk about is minimal change disease. And you'll notice the pathophysiology for minimal change disease involves increasing cytokines, podocyte effacement, and loss of the negative charge barrier. We said this is kind of a general pathophysiology for a lot of the nephrotic syndromes. So I want to draw your attention over here to our image, and you can see where our normal podocytes are right here. An effaced podocyte or podocyte effacement really has this kind of flattening structure. And so what this does is essentially it decreases its ability to work as a filtration membrane, and thus more molecules can get through. Why is this important? Well, structural damage to the filtration barrier, such as flattening of the podocytes, which can allow a leakage of more molecules, such as our protein, our antithrombin, and our immunoglobulins. So how is this condition diagnosed? Well, for the most part, this is technically a clinical diagnosis. That is to say that the damage to these podocytes can give a classic presentation in these patients that would be consistent with a sign of massive protein loss. So of course, we want to look at the urine and see, is there elevated levels of protein in the urine? These patients can also present with physical exam findings such as edema. They can present with other things such as the hypercoagulability, the high lipid levels, and the increased risk for infection, which we talked about in the previous video as being some of our classic signs of a nephrotic syndrome. And while getting labs or urine samples are obviously less invasive tests to confirm the diagnosis, you can ultimately get a renal biopsy to for sure say that this patient has minimal change disease. Typically, this is not needed, but for test-taking purposes, they'd like you to be familiar with a couple key images. So I want to go over those here. First, I want to make a point to talk about light microscopy and electron microscopy. These might not be terms that you're very familiar with. So just as a brief overview, a light microscope is essentially using light to look at the image. It typically creates a lower magnification than an electron microscope and also produces a lower resolution image. However, it's typically less expensive and potentially even faster to get this imaging. In contrast, an electron microscope uses electrons to get the image, typically a higher magnification, higher resolution, however, a more expensive test. So that's really all you need to know about these, is that there are two different ways of looking at a renal biopsy. So a key point here for minimal change disease is that on light microscopy, we have normal glomeruli. So if you look at this image over here, you can see that there's not any significant changes to the glomeruli. Overall, this looks like a pretty healthy glomeruli. So keep this in mind as kind of a normal picture, because when we talk about some upcoming pathologies, you're going to see some changes in the glomeruli that are going to look distinctly different than the one that we see here. So anytime you get an image that looks pretty reasonable or a question stem that says that the glomeruli looks normal on light microscopy, yet the patient still has symptoms of a nephrotic syndrome, you want to be thinking about minimal change disease. Sometimes I think about minimal change with images and that there's a minimal change in the patient, so much so that we're seeing some symptoms, minimal symptoms, but we're not actually seeing any pathology on the biopsy sample. However, if you take a closer look and you look at the electron microscopy, you actually see some of the podocyte effacement. Here you can see some flattening essentially of the podocyte. Instead of being big and tall up here, these ones are a little bit more squished down here. This is a classic finding of podocyte effacement. Now, for the management of this condition, the main one that they want you to know is prednisone. It's also important to know that MCD, or minimal change disease, responds well to prednisone. I'm highlighting this with a star because in upcoming videos we're going to talk about some other nephrotic syndromes which do not respond well to prednisone. This is a key differentiating feature. If a question stem tells you about a patient who has a condition, they're given prednisone, and they get better pretty quickly, you can think that it might be minimal change disease because you know that prednisone is a good treatment option and patients respond well. However, if the question stem says the patient gets treated with prednisone and does not have much improvement in their symptoms, you would be thinking of something other than minimal change disease because you're aware that there are other nephrotic syndromes in which we can use prednisone even if it doesn't have a significant benefit to the patient. And the final thing that we're going to talk about in this video are some key associations with minimal change disease. So the first one I want to highlight is that it's most common in children with a peak age of approximately 2 to 6 years old. What does this mean? Well, it means that typically in a question stem, although not always, they will present with a child having this condition. It's important to know that in the real world, of course, this can still present in adults, but oftentimes when they ask you questions on board exams, they're really focusing on a classic presentation. And the classic presentation is a child to be presenting with this minimal change disease, they're given prednisone, and they get better. Some other key associations include the association with Hodgkin lymphoma, upper respiratory infections, or immunizations. And the reason these are associations that can trigger this condition is that these are things that can cause an increased release of cytokines. And remember, we said that an increase in cytokines is one of the primary drivers that can lead to this condition. So a classic question stem might say, a 4-year-old child presents to the emergency department, they're having signs of swelling or edema in their body, they had a recent upper respiratory infection, which of the following is the best management option? Well, you can reason here from the patient's age, from the presentation of a recent upper respiratory infection, which could elevate cytokines, and the findings of edema in a young child, that this patient might have minimal change disease. You can continue to work this patient up by getting a urinalysis and looking at protein levels, and this could confirm your diagnosis, ultimately leading you to a management option of prednisone for the patient. And the final thing I want to mention here that's pretty unique to minimal change disease relative to some of the other nephrotic syndromes is this thing called selective proteinuria. And what this means is only albumin is lost in the urine and not the immunoglobulins. Remember when we did our overview video, we said that one of the classic findings of nephrotic syndrome is a higher risk of infection because we lose immunoglobulins for a lot of nephrotic syndromes. However, this is one that is an exception to that rule. While other glomerular diseases are what we call non-selective, this is a type of selective proteinuria where only albumin is lost. And that's why in these patients, we might see the frothy urine, we might see the edema, but we're less likely to see an elevated risk of infection. We're less likely to see them have a decreased amount of immunoglobulins because these are not typically passed into the urine with this particular type of condition. So again, a really good way to kind of learn this information is learn about all the similarities and then think about 1 or 2 things that make them unique or separate them from some of the other conditions. Because if you're starting to think like a test writer, you're going to do a better job of answering test questions. And test writers want to differentiate, can a student tell the difference between this nephrotic syndrome and this nephrotic syndrome? And the way to do that is to know the couple of things that are different between the large group of nephrotic syndromes you need to know. All right, great job everybody in this one. I'll see you all in the next one.